All right, so I get the best part of presenting in the afternoon as everybody is digesting and falling asleep. I've got to keep you with me. I want to make a comment about tomorrow's program so that you're all aware of some of the breakout things and one of the changes that we had to come up with. On the schedule, I can find my glasses, for Saturday's breakout, if you'll notice the 10:50 a.m. is the relationship with my name, and then sex is missing a name. So I have the honor actually of working with Dr. Jung, and she and I are going to combine relationships and sexuality starting at 10:50. So I really encourage you to come because we want to make this an interactive process. I don't want to talk at anybody at that point. She doesn't either. We want to make this an opportunity for you to come and bring up your issues and ask us questions so that we can try to help problem solve for you and give you some tools about how to deal with this. So we're going to combine sexuality and relationships at 10:50, and then I'm still going to do the behavioral relaxation for chronic pain management at 12 o'clock. Okay? And we might spread that around tomorrow morning so that everybody's aware of that as well. Okay? All right. So, let me get this going here. The thing that I do is I help people understand the nature of pain, not just from a medical standpoint, but the emotional impact that it has. And so I'm going to start by asking you to pay attention to this overall idea. This is the takeaway for everything I'm going to talk about, and the idea that pain is not only a sensation in terms of what you feel, but it is also an emotion. And the two are they're linked all the time. And I'm going to show you how that's done and how it affects Chiari, any other types of pain and emotional problems that you may have. So, here's what's interesting. If you have chronic pain, and I want you to understand the idea that chronic pain is something we usually define as happening after about 3 months of having pain. It's a temporal concept. So, acute pain is usually pain lasting less than 3 months. Chronic pain is 6 months or greater. What's starting to happen at this point is that treatment isn't really working, or the diagnosis hasn't been clearly flushed out, and so now the pain is really having an impact. And emotional problems develop as a result, and so when you have somebody with chronic pain who is either depressed and or anxious, it becomes quite difficult to determine what's going on. How much of this is physiological, how much of this is medical, and how much of this is emotional. And so from a somewhat common sense standpoint, it's fairly obvious that when you have pain, it can be frustrating. Frustration can lead to anger. It can lead to things like worry, anxiety, depression. Okay, so you have that emotional consort again that's going along with it. You have the physical sensation and the emotional reaction. So I've done a graph here just to have you be able to conceptualize what we're talking about. So if you notice the direction of the arrows, everything is moving outwards from the pain that you're experiencing, creating these variety of emotions. And I could put more and more circles. You could have guilt under there, you could have anger, you could have shame, you could have all sorts of emotional responses as a result of pain. Okay? So here's what's really interesting. The opposite can also be true, and one of the things I find in my work is there's always seems to be this sort of bipolar component. It can go both ways, so that the physical sensations lead to emotional reactions, the emotional reactions lead to physical reactions. And so negative mood, negative emotions can not only exacerbate pain, but they can cause the sensation of pain without physical problems. And that's where I want to show you how we try to distinguish what's what and why that's so difficult diagnostically many times. So now look at the graph. What's going on is I've reversed the arrows, and I could have put a lot more squares around that as well. But here, we're getting these physical sensations of pain as a result of the emotional issues in the absence of anything metabolic going on. Anger can be at many different levels. Can you imagine when somebody is in a rage, how physically tense they must be? So as a result, you're going to get physical manifestations of those types of different emotional constructs. So I've gone both directions again. Remember, pain is not only a sensation, it's also an emotion. All right. Interesting finding. Look closely at what this slide is saying. If we take something like depression in a patient who does not have any pain, they are twice as likely to develop chronic musculoskeletal pain than a patient who is not depressed and pain-free. So in this example, just having depression can lead to physical pain. All right. What we call this in psychology a lot of times, these physical symptoms of emotional distress are the vegetative symptoms. And I want you to once again look at this sort of bipolarity that's going on. So people who are depressed oftentimes have a loss of appetite. Just as common, and sometimes even more common, is a tendency to overeat as a way to manage the emotional distress. And although we think of things like using alcohol or drugs to help deal with emotional stress, I also consider overeating a form of what we call self-medicating, because it's instantaneous. You get that thing in your mouth, it feels better, you feel better momentarily, but it's not long-lasting. So, loss of appetite or excessive eating as a vegetative symptom of depression, a physical manifestation of an emotional state. Sleep is the same way. Oftentimes people who are depressed or very anxious cannot sleep. They can't turn their minds off. It's going on and on and on. Also, interestingly enough, other people develop the capacity to oversleep as a way to avoid. Now, interestingly enough, I have chronic pain patients who have very little functionality, yet they've developed mechanisms to sleep through their pain because it's the only time they get any relief. So although oftentimes sleep deprivation and insomnia are associated with chronic pain, I also have patients who sleep to avoid their pain. Either way, it's very dysfunctional because they have no quality of life. Fatigue is another manifestation of depression, and fatigue is also a manifestation of chronic pain. Very common, unfortunately, along with Chiari, is that we have this loss of energy, this fatigue. Well, this can be a manifestation of just straight depression. Impaired attention and concentration. This is about the thinking components that many of you struggle with, and this is also occurring just in depression by itself. And when you can't concentrate, when you can't attend, you can't remember. So short-term memory goes down the drain very quickly. You have difficulty making decisions. Executive functioning is affected negatively by this. And then the thing I've put at the bottom, which is actually where I began about these vegetative symptoms, is that patients who are depressed without physical problems will talk about their whole bodies or parts of their bodies aching or being in pain. So, psyche and soma, mind and body, they're always connected, they're always interrelated. Now, over the past day and a half, you've seen a lot of technology, a lot of pictures, a lot of scans, a lot of MRIs. This is a little less sophisticated, but actually quite interesting, because I want you to see what your brain looks like when it's depressed. And I need to go to my screen and slide over here. Look at the activity on the right side. There's all of this cortical activity going on when we're not depressed. There's all this functioning going on in the brain, and interestingly enough, there's very little going on in the brain when we're depressed. Makes a lot of sense. Now, what's also interesting, we talked about depression having physical manifestations. Anxiety can also lead to manifestations of physical problems and physical ailments and physical pain. So, I showed you, let me go back. Remember this picture, okay? Depressed brain. Now we go to an anxious brain, and just the opposite is happening. So if you look at the right side, this is a patient with obsessive compulsive disorder, which is one of the categories in the anxiety disorders that I treat. These people cannot stop, they cannot slow down, they can't stop checking, they can't stop thinking. And so there's this massive amount of activity going on in their brains. But I want you to be able to see that we are now getting these objective correlates of what's happening emotionally. This is not just something you feel, it's something that's actually going on in the brain. So let's go back to the beginning for a moment. Pain is both sensory and emotional. That means it is multidimensional. Here's the interesting thing. When we talk about the sensory inputs, three things are going on. First of all, we have to know where we're feeling the pain. Once we locate it, we can tell ourselves and others indirectly what the intensity is. Oftentimes we use that 0 to 10 scale. How bad is that pain? And what is the quality of the pain? Tight, throbbing, hot, cold, stretching, gnawing, tearing. There are all sorts of subjective terms for the description of the pain. So that's the sensory component. But interestingly enough, the second half of this slide where I talk about the cognitive emotional aspects, without the cognitions, which is a fancy term for thoughts, you can't do the upper half of this slide. So in other words, what begins to happen is, in order to be able to locate the pain, you and I have to perceive it. We have to notice that it's there. Some people are actually very good at blocking pain, and I'll talk a little bit about that later on in another aspect of this. But you have to perceive the pain. That's the cognitive component. And before I can tell you not only where it is, but what it feels like, I have to interpret it. And my interpretation of my pain may be completely different than yours. So my 6 may be your 10, or just the opposite. So I'm not only interpreting the pain, but based on my interpretation, I have a reaction to the pain. And then we come back to things like fear and worry and anger and depression and guilt and sadness. Okay? Always linked, multidimensional. So let's talk a little bit about the cognitive emotional aspects, because that's my wheelhouse. That's where I'm helping people manage their chronic pain. And the idea here is when I'm doing an evaluation of a pain patient, I want to be able to look at a variety of factors. And one of those factors is self-efficacy. And what that's basically saying is, what level of confidence does the patient have or not have in their ability to cope with the pain, and what impact that may be having on her or his life. Okay? And self-efficacy runs the gamut from people who have very low self-esteem, who feel helpless or hopeless over their control of their pain, to people who won't let the pain stop them for any reason whatsoever. So self-efficacy is a huge component about where do I start with this individual in terms of their sense of whether or not they can affect change in their symptoms. A concept of self-efficacy is this idea of acceptance. I want you to look in the middle of the slide about this notion of what we call psychological flexibility. If you remember back to the slide that I showed you about the obsessive-compulsive individual with the high glucose metabolism, people with obsessive-compulsive disorder have what we call cognitive rigidity. They are very, very inflexible. Everything's got to be a certain way, and we all have varying degrees of whether or not we're perfectionists, whether or not we have to have everything in order. And so when you deal at that end of the spectrum, if you don't have much flexibility and you're dealt the hand of something like Chiari, you're dealt the hand of chronic pain or functional limitations, and you only know one way to do things, you're really stuck in a box. And that's a lot of the work that I have to do, is helping people improve their flexibility. So an example of a patient with cognitive flexibility is the statement just below, which basically says, it is what it is. Now what can I do to manage it, since it may not disappear? And I really want to focus for a moment on that concept of the what can I do, because oftentimes in the medical community, we go to physicians looking for solutions. And there is this expectation and dependency that develops that they're going to make us better. Oftentimes when patients come to me, I have to change the boundaries immediately, and I have to say, look it, I cannot make your pain better. What I can do is teach you the skills necessary to perhaps manage your pain better and to be more functional. So a lot of the responsibility in my work with the patients rests on what they are doing and my expectations in them doing those things if I can provide them the tools. So it's what can I do as part of this to become a partner in my treatment. So now let's step back for a moment. Fear-avoidance construct is very important because pain is an aversive stimulus. I mean, nobody likes to feel pain. Small percent of the population that we would diagnose as masochists who actually enjoy pain, but we're not here to talk about S&M. That'll come tomorrow in the sexuality piece. Dr. Vez talked about latex last night, but I won't go into that with you any further. So one of the interesting things about pain and having it for an extended period of time, over 3 months or more, is that what starts to happen is you can have different conditioning patterns, and that can occur consciously or unconsciously. And so what happens, of course, is when we first have pain, we want to try to figure out what are the things to do to avoid it. Because if we don't do this, then it won't hurt. And one of the classic things I hear working with orthopedists a lot of times is, it hurts when I do this. And the doctor says, well, don't do this. But of course, you begin to restrict everything and you really start to get into trouble because the avoidance actually can lead to increased pain. And so let me show you this graph. We start off with pain. One of my favorite words is this really long one called catastrophizing. Another great word that was made up by a colleague a while back is called awfulizing. Everything is awful, terrible, horrible, I can't stand it, it's the end of the world. And when you engage in catastrophizing, what begins to happen is you create anxiety. The pain really doesn't cause you to be anxious, it is your interpretation of the pain. So if you catastrophize, somebody who is anxious by design, assumes the minute they have something wrong with their body that it's cancer and they're going to be dead in 2 weeks, that's catastrophizing. And when you do that, you magnify the emotional reaction because your interpretation is off the deep end. So what happens? You get anxious, and what starts to happen is you have fear of more pain, or it's not going to go away, or it's never going to get better, or I don't know what to do, and you're just winding it up and winding it up and winding it up. So what starts to happen is you engage in those avoidance or escape behaviors. Here's the diagram. Because I was off one, I'm sorry, from the computer here. So, pain, catastrophizing, anxiety, further fear, and avoidance. Here's another graphic manifestation of that. Look at how this builds. And at the very top, we can put in anxiety as well. I didn't have the room for that. So basically what's going on here is you're in pain. You begin to restrict and isolate. That can be physically, that can be socially. You start to withdraw from engagement because things hurt. As a result of that disengagement, there's actually atrophying and deconditioning that takes place. So not only do you have the original pain, but as you become atrophied and more deconditioned and you try to do something, you have pain on top of that. Okay? And then what happens then is it gets worse and worse, and essentially you have pain on top of pain on top of pain, and what's the emotional outcome? This is really depressing. And it's really frightening because I don't know how to get out of this cycle, because what I first tried to do was avoid anything that would cause me to have pain, and now it's even worse. The next slide is a one-paragraph statement of what I try to accomplish in therapy, and I'm not doing a therapeutic talk today. I just want to show you that one of the things that we try to do in terms of behavioral medicine and pain psychology. Confronting the pain is actually the most helpful thing to do. It's frightening, I understand that. But if I can teach a patient to think differently about their situation, about their circumstances, and manage the anxiety and reduce the catastrophizing, if I can get them to be aware of how they make it worse themselves, what starts to happen is I don't actually expect that the pain drops, but their capacity to manage the pain improves. And so when it is what it is, now what can I do to manage this, starts to happen upstairs, then what begins to happen is not only do they tolerate the pain better, but their functionality improves because oftentimes they allow themselves the possibility of doing things that they were previously avoiding or isolating. Okay. Here's the great classic picture. Everybody check his or her wallets or pocketbooks at the end of this talk because I will have your credit card numbers and bank account numbers. Okay. So I love this picture. This is probably out of the 20s or the 30s because it identifies a lot of bad thoughts and ideas that we have about clinical hypnosis or the use of hypnosis, the ideas of people being on stage, clucking like a chicken or barking like a dog, those types of things, stage hypnosis. Little education, because the more you know, the better off you are. And when there's less ignorance, there's less fear, and when there's less fear, then you're willing to understand and try things at a different level. What's really interesting is that when people think about being under hypnosis, it means you're in a deep sleep and somebody has control over your mind and your body. But what's really happening here is that it's a heightened state of concentration. There are 4 basic brainwave states. Very easily, I remember the first 3 as BAT, B-A-T, and then add a D at the end of it. So we have beta, we have alpha, we have theta, and we have delta. Beta is what's going on right now. Some of you are probably in delta because I've put you to sleep, and you're really not here, and you're digesting. But what's really interesting is when you start to get sleepy, you move into an alpha stage. And then you go into theta, which is accompanied by dreaming, and then delta, which is deep, deep sleep. There's no imagery going on. There's no dreaming, essentially. Under a hypnotic state, what we notice, the brain waves, are that there's a lot of beta activity, and there's this focused awareness, even though you may be disconnected from what's going on around you, okay? The most important part is the bottom of this slide. Everyone, okay, there aren't many constants around, but everyone experiences hypnotic trance states. And I'll give you a classic example. This is a perfect venue for a trance state, and I'm not really joking here. I'm sure all of you can remember being in school at some point and the teacher is blabbing on and on and on and on, and you're daydreaming. You're not even in the classroom, you're somewhere else. How many of you have driven home? It's late in the evening. You've made every single turn, you've stopped at every stoplight, and you don't remember any of that, and all of a sudden, you're at the front door. Those are trance states. Those are dissociative hypnotic states that we all experience. Getting lost in a piece of music is an example of an hypnotic state. So we all experience trance. I want you to understand that. No one can hypnotize you. All they can do is facilitate entry into a trance state. So you have to allow that to happen, and you allow it to happen all the time. It happens to all of us every day. We just don't recognize it. Why is that important? We've done some studies here neurologically that are really fascinating. And what we did was we applied a noxious stimulus, a painful stimulus to a patient, and we said, look it, what you're feeling right now is going to change. This is not going to hurt as much. It's not going to be as painful. It's not going to be as overwhelming, but it's still going to scare you to death. What was really interesting was that suggesting under a dissociative or trance state, we discovered that this area of the brain that's highlighted, the somatosensory cortex, which is involved in the sensory component of pain, changed. That activity area changed. Completely different part of the brain than the emotional part. So under suggestion, we changed what the pain was feeling like for them without telling them to change the emotion, and one part of the brain shifted. Here's the obverse. Now we take a patient and we say that what's going to happen is this burning sensation you feel is not going to change, it's not going to go away, but you're going to start to notice that you're feeling a rather pleasant sensation emotionally. This isn't going to really bother you, even though it's really, really hot. It's really, really hurting. And if you look at this picture and you remember what I showed you previously, this is on the outside, this is on the inside. This is part of the anterior cingulate cortex, which is part of what we experience with emotion, the amygdala, the hypothalamus. This whole area is the emotional construct that's going on when we are experiencing things emotionally. And so what we've discovered under hypnosis is that different parts of the brain can actually be manipulated, and that's huge in terms of pain control. So what do we learn from hypnosis? 25 lessons. This is available outside next to the t-shirts. I love this picture. I think this is also from the 20s. So the emotional factors can frequently affect our experience of pain. And what I want you to think about is this term suffering. Suffering is a subjective term. It's what you and I have to describe our pain, because nobody else can feel what you and I feel. But what's interesting is that if you have this emotional sensation, it doesn't necessarily mean the pain has changed. It's just how you are responding to it. And so, borrowing off of that, and where I go with psychology is, the amount of fear you have about your pain, how terrible it is, how horrible it is, how awful it is, actually predicts the degree of disability rather than the actual pain intensity. So if we scare ourselves badly enough about this pain, we will paralyze ourselves in a sense emotionally. We will withdraw. Okay, this comes down to emotions. And one of the things we discovered, and the reason we know this is true, is the use of benzodiazepines. I'm sure all of you have either heard or some of you have perhaps tried Xanax, Ativan. These medications have absolutely no analgesic properties. They are not opiates. They're not like hydrocodone. They're not like Percocet, OxyContin. They don't have an analgesic effect. But when we give pain patients benzodiazepines, why does their pain level go down? Because we reduce their anxiety. So there's that component again. Pain is sensory and emotional. And so what's interesting about this, and what I'll be doing tomorrow at 12, is leading the group who wants to come in some deep relaxation techniques. We're going to be handing out CDs of the relaxation process so that you have something tangible to take home and work with. And as you learn to master emotionally calming down, you may find you have better control over your pain. And that's what I'll be doing tomorrow. Whoops. I just went the wrong way. Okay. So, brain scans of pain. How am I doing on time? Okay. We're getting there quickly. So here's the interesting thing. When I ask you, how does your pain feel? All I know is what you tell me, but I can't objectively feel that. So when I say, what is your pain like on a 0 to 10 scale? The problem, of course, is, as I said earlier, your 8 might be my 2, or my 2 might be your 8. So the problem is there's nothing clinically objective about, tell me about your pain. It's your pain, so it's highly subjective. But now we're beginning to see some things that are allowing us to get an actual signature of pain, which I find really fascinating. Now, you've seen a lot of these pictures. I just want you to look at this for a moment because it doesn't have to mean a whole lot, but this is a signature of pain. And there's a guy by the name of Tor Wager who is out of Boulder. This is back in 2013. And when I discovered this as part of this talk, I got really excited. So I have to do some more reading about this. But one of the things that's really interesting was he found that there was this distinct neurological pattern for pain, which was separate from emotional. And in the past, when we've done scans, when we look at the brain activity of people with pain, we see similar things in people who have emotional pain or distress. He's found a distinction. And what he expected and didn't find that was really surprising was everybody's different, everybody has different pain. As a result, we should have a different signature. And what was really spooky about what he found was that they had a 90 to 100% rate of finding this same signature of pain no matter who the patient was or what the problem was. And then what was even more interesting was we added an analgesic and the signature changed. So there's a lot of predictive potential, not only for mapping specifically where pain is getting fired off in the brain, but on my half of the field over here, we're also finding there's a distinct neurological pattern for emotion. And what I believe is going to happen with this eventually, it might take 10 or 20 years, is we're going to be able to start to design treatment that not only manages specifically where the pain is in terms of neurologically, but also what does a map of anger look like? What does a map of depression or anxiety look like? So this is really exciting stuff. Okay, let me move on quickly here. So, very last part of this, I get to beat up on the physicians for a moment. Okay. Here's the thing I want to give a shout out, and this is not to just the clinicians who are in this room, but to all of you who are also patients and family members. This is a really important takeaway. Traditionally, psychological services, especially when we're dealing with pain, come at the end of treatment because physicians are trying to diagnose, and they're not really taking into account what's the emotional status of the patient. How is this affecting them? Okay? And so many times when they can't find the right diagnosis, it's like, I don't know what's wrong with you. I think this is all in your head. And what's the message to the patient? Well, you're the problem, because I can't help you, and if I can't help you, it's all in your head. And so I have to do a lot of damage control when patients come to me with that message because a physician or physicians hasn't found the right diagnosis. So, last slide, most important thing. Ideally, and at the very least, when you get involved in treatment, and even now if you're halfway through it or you've been through it for a while, please try to find out if your physicians have anybody in terms of behavioral medicine or pain psychology that can at least do an initial evaluation to find out, is there depression going on? Is there anxiety? Is this affecting the way I'm coping with this pain? And perhaps are there things that I can do to make it better? Okay? See you for sex tomorrow. Thanks.